All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app. Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day NBIM NAMS, NAMS Task Forces, AIIMS NAMS Navigate Medico CME, CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app. Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day NBIM NAMS, NAMS Task Forces, AIIMS NAMS Navigate Medico CME, CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app.
गुड आफ्टरनून सर।
हाँ सर, साउंड क्लियर है?
हाँ मुझे साउंड क्लियर है आपका।
बिल्कुल, आप बिल्कुल परफेक्टली क्लियर है, कोई प्रॉब्लम नहीं। ओके सर, 3 मिनट से स्टार्ट कर देंगे हम,
राइट,
वीडियो के साथ। ओके।
How long you have been there now? 4 साल हो गए, more than 4.
Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day NBIM NAMS Task Forces, AIIMS NAMS Navigate Medico CME, CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app.
Hello and welcome everyone to the next start.
Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint NAIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the NAIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on the first Friday of every month from 3 p.m. to 5 p.m. The NAIIMS NAMS CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medical CME is to help them to be more proficient in their profession. Each session will cover 2 topics. Each topic will be of 1 hour duration, which includes 45 minutes for presentation by speaker, 15 minutes for questions and answers. Thank you for your kind support.
Good afternoon, everyone. Welcome to the next series of AIIMS NAMS Navigate Medical CME program. And this time the series begin with the lectures from ophthalmology division. So it would be amazing to have all those interesting lectures. So now to begin with the session, I would like to request Professor Umesh Kapil sir. Sir is the Secretary of National Academy of Medical Sciences for the welcome address. Over to you, sir, please.
Thank you very much, Jaswant, for we are grateful to our speakers, Dr. Dr. J.K.S. Parihar, Dr. Pradeep Sharma, and all the participants who have joined for this Navigate program. Essentially, we started this program about 2 years back. The aim is to provide continued medical education to all the doctors in our country, including the doctors who are serving in the primary health center, community health center, district hospital, medical colleges, and other medical institutions. Now, keeping that thing in mind, we select the best and the most eminent scientists who have earned a name and fame in their respective field. Keeping that thing in mind, we started a series of lectures in the field of ophthalmology, and we have with us Dr. Pradeep Sharma today, who has served for almost 40 years at All India Institute of Medical Sciences and developed the specialty of strabismus. This is something very important, and presently he has joined another super specialty hospital, which is Center for Sight. The aim is that we should have all the doctors who can join us, and those who are unable to join, these lectures and PowerPoints are available on the NAMS virtual library that is on NAMS website for all time to come. So all the lectures are being recorded and we put up them on the NAMS virtual library. Also, we have another thing is that we have almost right now 179 people have joined online and seeing us in the YouTube. So YouTube channel is also there. We share the link with all the participants all over the country. We have about 1100 postgraduates and faculty members who are part of our Navigate program. So, keeping this thing in mind, we have initiated the Navigate program to deliver the state of art lectures. With this, I close my remarks. Welcome address. Over to you, Jaswant.
Thank you, sir. Thank you for the welcome address. Now, I would like to request Mr. Raviji for a message from President National Academy of Medical Sciences, Dr. Digambar Vera, sir. So, we'd like to listen to his message.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you. Since it's a joint program from AIIMS and NAMS, next we would like to listen to the message from Professor M. Srinivas, Director of All India Institute of Medical Sciences, New Delhi. Raviji, please.
Namaskar. At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of the department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Well, now it's our turn and our privilege to introduce the chief coordinator for the ophthalmology series. So now it's my privilege to introduce the chief coordinator, Major General J.K.S. Parihar, sir. Sir is Professor of Ophthalmology and Head of Academics and Training at Center for Sight, New Delhi. Sir formerly served as Additional Director General, Armed Force Medical Services. Sir has also chaired professional societies, including President Eye Bank Association of India, President-elect IIRSI Intraocular Implant and Refractive Society India, Vice President ACOIN, Executive Team Member in Global Alliance of Eye Bank Association, Governing Council Member of Association of Asia Eye Bank of India. Sir has a long 34 years of teaching experience. Sir has been head of the education at Armed Force Medical Services. Sir Sir also published more than 125 articles, 5 books, and 25 chapters. Sir has taught with live surgeries and scientific presentations, which were more than 750. Sir has very huge research experience, including more than 30 extramural projects, 6 intramural projects, and innovations. His special innovation, that is color vision detection device (ICL). Also, sir has been member and office bearer of more than 33 ophthalmic professional societies. Sir has been awarded with Sena Medal, Bart Visist Seva Medal by the President of India, Commendation of COAS, VCOS, GOC, uh, Republic of Afghanistan Appreciation Award 2016, Distinguished Service Award by Asia Pacific Academy of Ophthalmology in 2011. Sir is also FAMS, fellow of National Academy of Medical Sciences. Also, sir has been awarded with Dr. S.D. Sarma Oration Award by National Academy of Medical Sciences, India. Sir is also been awarded with Air Marshal M.S. Boperoy Oration Award by Ocular Trauma Society, NSPB Award 2005, and Limca Book of World Record 2013 for performing phacoemulsification cataract surgery at the highest altitude in the world. So, sir has special interest in FLACS, glaucoma, keratorefractive ocular trauma, community ophthalmology, and eye banking, including medical education, research and innovation, university teacher and examiner, and PhD guide in ophthalmology. With this brief introduction, now I would like to request Major General JK.S. Prihar sir for his address to the participants. Over to you, sir.
Thank you, sir. Thank you. Thank you very much for your kind introduction. And I must, on the record, place my sincere gratitude to the then President, Dr. Sareen, present incumbent President, Dr. Digambar Behra, General Velu Nair, President-elect, Dr. Neerja Batla, Vice President, and above all, I would say, though it may not like sound well, the Professor Umesh Kapil for giving me expertise, advice, and guidance. With all these wisdom, we have planned this program of ophthalmic CME series. And as the ethos of this program is for the general interest. And keeping this in mind, we have carefully chosen the subjects which is of the very huge significance for the society. Like Professor Pradeep Sharma is going to talk about strabismus. It's not only the squid, but pediatric ophthalmology and its further compounded impact on the personality of the patient, and then the socio-economic affairs. It's a huge epidemiological problem, and eye banking, glaucoma, diabetic retinopathy, pediatric problems of ophthalmology. So these topics are framed, and we have chosen the faculties, those who can do the justice to this. Mr. Jaswantji, and with the request to the chair, Professor Umesh Kapil, I would like to introduce Dr. Pradeep Sharma myself. Dr. Pradeep Sharma, sir, is we are contemporaries and we have been seeing each other growing, but he is far, far ahead than of his generation. And if I would not be exaggerating, that the Pradeep Sharma is not only the instrumentalist of par excellence in our country, but I would consider him at least one of the best, topmost in the Asia and among the first 10 in the world. His technical, his surgical expertise, clinical acumen is far, far superior than so many peers in the all over the world. Above all, he is a great human being. He belongs to the School of Medicine of the British culture. Even today, when I went to him to remind him about his talk, he was so passionate. Even at 1:30, he was deeply engaged with the patient, and I kept on watching the way he was conducting from outside his door for 12 minutes. Phenomenal. So it's a great honor for us and for the, I would say, for the National Academy to have a lecture from Dr. Pradeep Sharma. Professor Kapil knows him, but better being in the same institution for years together. He was born in All India Institute as a medical undergraduate. He finished his post-graduation, he became faculty there, and he rose up to the acting chief, which acting chief was practically like a tenure of any chief of RP Center. So that shows his professional journey. I'm honored and privileged to introduce you, sir. Extremely grateful on my behalf, entire ophthalmic fraternity and entire National Academy that you have consented and now going to bestow upon us with your wisdom of pearls on strabismologists. Thank you very much, sir.
So, since the introduction been done by Major General J.K.S. Parihar, sir, so it's our privilege to listen to Professor Pradeep Sharma, sir. So, without wasting much time, I request Professor Pradeep Sharma, sir, for his pearls of wisdom for all the listeners and participants.
मैं शेयर कर देता हूँ आपकी स्क्रीन। Thank you, Professor Parihar, Professor, for that wonderful introduction, which is
I'm really grateful, and I wish I was as good as the words you mentioned. At the outset, I would like to thank the NAMS organization, which has done this wonderful job of starting this Navigate series for the purpose of PGs and ophthalmologists all over the country, as well as maybe through the web in different parts of the globe. For that reason, I would like to thank the present president, Dr. Behra, Dr. Secretary, Dr. Umesh Kapil, for doing this wonderful job. So without going into much details, I would now start with the job which is at my hand today, and that is understanding strabismus, the pursuit of stereopsis. What do we mean by this? Generally, you must have seen our education system has been rote learning, and we have wonderful students who come through NEET and through PG entrance exams, and they are turned out into donkeys. We need to change this system to make them more practically oriented and learn so that they can serve the people of our country as well as the globe. I have no financial disclosures relevant to this talk. So let us come to this. What are we dealing with? Ocular motility is a play of 12 extraocular muscles in 9 gazes. So if you take an analogy of the astrology, we have 9 houses, we have 12 houses and the 9 planets which do the mischief in these 12 houses. Here, with a little change of numbers, we have 9 houses of 9 gazes, but there are 12 extraocular muscles, 6 in each eye, which are going to create mischief and create problems like squint. Moreover, how do we see? We are having these 2 eyes and which are giving us the visual images in the 2 cortex. And if you go into the fine details of the occipital cortex, you will see the right eye and the left eye are having dominance columns, the ocular dominance columns, which are monocular till the level of 4C. And after that, the synapsing occurs to give us binocular vision possibility. And this gives us to the depth perception that we all enjoy. And that is something which is the greatest achievement in all the animal kingdom. So what is binocular perception? The 2 eyes are having 2 different images. The right eye and the left eye are actually seeing little differently because of the horizontal displacement. And this creates the parallax. Now, these 2 images are more or less similar, but there are some subtle differences, and these subtle differences is what is going to create stereopsis. So in the alignment of the 2 eyes, the 2 visual axes meet at the point of fixation or regard. The 2 foveas share what we call as a common visual direction. So when they are both in alignment, we say it is good alignment, and when they are not aligned, then is what we call a squint, strabismus, or an ocular deviation. So what is binocular vision? When both the eyes are in alignment and they have a foveo to foveal correspondence, this is what we call also as the normal retinal correspondence or a bifoveal correspondence. All the other retinal points, now mind you, we have so many several points which are giving a composite image for each eye. And for each and every point, there is a point-to-point correspondence between the right and the left eye. And these corresponding points, when they are stimulated, gives us a binocular single vision, and there is no diplopia. But if there is a stimulation of the disparate points, it gives rise to what is called as diplopia or double vision. What is horopter? Horopter is basically a plane of vision in front of us at any fixation point. So for each fixation distance, you will have a horopter. So this horopter is not going to be totally flat, but it is going to be a little curved thing. If you draw a circle and do a geometric construction, it will be known as a geometric horopter. But what we actually see, the physiological horopter, is little more flatter. And this difference is known as the Herring-Hillebrand deviation. So for PGs, this is the difference between the geometric or the Wieth-Muller circle and the horopter that we see, empirical horopter or the physiological horopter. And just in front of this horopter and behind, there are areas which are going to stimulate little disparate points, but these are still possible in the brain to fuse, and this is known as the PGIMER area. The importance of PGIMER area is any disparity within the PGIMER area gives us a binocular single vision. Anything which is outside it will cause double vision. So what we see as stereopsis, you must have seen that the right eye and the left eye are seeing little different images, and in the brain these are fused together, and these small disparities are actually fused by the brain, and this is what gives us the 3D effect or the stereopsis. So if you have gone to see a 3D movie, you must have seen the visualization of this 3D in a more different manner, but day to day you are seeing a 3D effect all the time. You may see with monocular clues some 3D, which is known as the monocular clues, but when you close one eye, you do not have a real depth perception. And in critical jobs like flying or even driving or even doing a precision surgery, you will require real 3D vision. So the small animals which are there, they have laterally placed eyes. The eyes are on the sides, which gives them a large panoramic view, almost like 270 degrees of field, which is going to protect them from any danger coming from any one in front, sides, or even little behind. But the predator animals are having the eyes more and more frontally placed so that they can have a depth perception. They can have the fusion of the two images and give us the depth perception so that they can have a good judgment on the prey and pounce on it. So an eagle or an owl or the tiger, they have much better binocular vision, but the best is with the human beings. Now, the importance to know of this binocular vision is that as long as the eyes are in alignment, it's an asset. But just like any asset can become a liability if it is wrongly placed, like if you have a lot of money in your closet, it's fine. But if the income tax officer comes in, you would like to be in trouble because of that, and it becomes a liability. So similarly, if you have the two eyes, it gives us binocular vision, but when they are not in alignment, it becomes a liability because it gives rise to one, asthenopia because of the two images and causes an headache. It's a double vision. Confusion between there are two images, just like you have more than one choice for a party dress, you are having confusion which to wear. But here, if you have just one, you have no problems. Past pointing will be there in immediate paralytic strabismus, vertigo because of the double images, and even psychosocial problem because of a presentable squint which is not appealing to people. So how does the brain cope up with that? These are adaptations. One is head posture. If suppose there is an incomitant strabismus, meaning thereby that the eyes are having no squint in some position, then the head will be turned to take advantage of this position so that the person will still be able to see binocularly in spite of the squint being in other positions. Or you may have a blind spot mechanism, that means an esotropia of 12 to 15 degrees, then the other image falls on the blind spot, where the optic nerve is exiting from the globe. So there are no rods and cones, so the person will have no vision. So there will be again freedom from diplopia, so that's a blind spot mechanism. So these head postures may be there in three forms because we have three dimensions of freedom of movement. So you have a face turn right or left for the horizontal deviations, a chin up and down for the vertical deviations, and a torsional deviations, we have the head tilt to the right or the left shoulder. The other mechanism of taking care of these misalignments is a sensory adaptation. In childhood, the brain is very active and it can easily suppress a double image. So that is known as suppression of one image. Now, there is an advantage that you will have no confusion, no diplopia, but you would have lost all the advantages of binocular vision also. So this is not something which is desirable. On the other hand, if there are small angle squints, then there can be what we call as a harmonious ARC or harmonious anomalous retinal correspondence. So what is happening is there is a binocular advantage still there. What is happening in the cortical level is that the two images which are coming from two different ocular dominance columns, but they are close by in the cortex, up to 8 to 10 prisms away in the terms of deviation. So these will be synapsed or resynapsed, and this resynapsing gives rise to a harmonious anomalous retinal correspondence. So here we have a foveo extrafoveal area which is giving us correspondence. So it's also called as a foveo extrafoveal or harmonious anomalous retinal correspondence. Now, just to make the situation a little light to understand, it's like a situation normally that in the brain, the two strangers come together, like a boy and a girl come together. The same with ocular dominance columns in a child and an infant, they are coming together. They can have a normal synapsing and gives rise to a normal correspondence, or similar to a harmonious marriage between a normal relationship boy and a girl. But if suppose both these ocular dominance columns are very strong and separated, misaligned, then what can happen? Because they have two different viewpoints, just like two couples having different viewpoints, but both are very career dominated, then they may have a individual existence. They may live separately or get divorced. So similarly, in this, we may have binocular vision is lost, but there will be a monocular vision in each eye, but the vision may be 6/6 in each eye, but no binocular vision. Or there may be a situation in which one of the sides dominates, just like in a couple which is asymmetric, which is having one dominant couple and the other one is totally suppressed. That will give rise to a situation of good vision in one eye and a very poor vision in the other eye, which is akin to amblyopia or lazy eye. So this is what we mean by amblyopia, which may be there. So what is amblyopia? A developmental anomaly of vision. We are not born with 6/6 vision, mind you, but in our early childhood, especially in the first 9 months of life, we are going to acquire very good vision from almost like 6 by 600 to 6 by 18 or 6 by 24. And when the person is around 5 or 6 years, he gets 6 by 6 vision. So this cortex is learning a new language. So I call vision as a new language. And just like any language, we learn very good in our first 5 years of development. Just like if you're born in China, you would have learned Chinese so easily. But if you are now posted in China, you will have a lot of difficulty in learning. You can still learn it with a lot of effort, but it will be much more difficult to do it. But if you're born in the first 5 years, then there is much ease. So same way, a vision which is normally developed in early 5-6 years is fine, but we can restore the amblyopia or correct it if we can detect it in the first 5 years and correct it properly. So for theory, the definition is mentioned on this page. What is the diminution of vision in one or both eyes? And what are the causes of this? It can be a stimulus deprivation amblyopia. That means something is blocking the vision of one of the eyes. It may be because of a cataract, a corneal opacity, or anything which is in the vitreous, a vitreous hemorrhage which is in childhood. They all can create a situation of stimulus deprivation amblyopia. Or it may be a very high refractive error. Then also there will be a problem. So if there is an asymmetric between the two eyes, one of the eyes may get normal vision, but the other eye which is having a higher refractive error, then it may develop into an anisometropic amblyopia. So one eye is having good vision, the other eye will have poor vision. Or it may be a situation of misalignment, a squint, mostly an esotropia, in which situation one of the images will be suppressed, as we talked about earlier, and this will give rise to an amblyopia of one eye, the strabismic eye or strabismic amblyopia. Other situations like nystagmus, the eye movement which are happening uncontrolled, or any other causes of maybe there which may also affect the development of vision, can also be causing a mixed etiology, and even sometimes partly it may be organic and sometimes functional amblyopia. Now let's understand that if a child is having a refractive error, if he is type A personality, that means he wants to see clear, then he will exert his accommodation to see things clear, and this accommodation use will give rise to what we call as accommodative esotropia. So one eye will have clear vision, the other eye will have an accommodative squint, convergent squint, and that eye will suffer a lazy eye. On the other hand, if there is a lazy, happy-going, lucky child, he will not bother to see clear, and he will develop ametropic amblyopia of both the eyes. So there will be a refractive error which affects both the eyes equally. That will be an ametropic amblyopia. So in both the situations, if they are not corrected in childhood, it can give rise to amblyopia. How do we correct amblyopia? So the simplest mechanism would be to give the opportunity to the lazy eye, amblyopic eye, to be used. And this is done simply by patching the good eye. So it is similar to like what we have in the society, that we may give more affirmative action to the weak eye, more support to the weak eye, and that gives more chance for it to improve, and the other eye can be occluded or patched. And there are different schools of thought, maybe of patching, that we may do unilateral patching for 3, 4, 5, 6 days of a week, or it may be part-time occlusion. That means 6 hours of the dominant eye occluded regularly. The concept of occlusion hours is to be understood. That means that it's like how much time the lazy eye is supposed to be used that will make it work better and faster. So it has been seen that almost like 120 occlusion hours are required in order to improve 1 logmar improvement of visual acuity. We can also assess this process by active vision exercises. So letting the lazy eye see more often, it may be helped by what we call as monocular perceptual learning. We can give monocular video games play. That means giving only chance to be seen by the amblyopic eye and the other eye being patched, and he's allowed to use video games also. Or nowadays we have what we call as dichoptic perceptual learning. That means on the virtual games, we can make him play right and left eye seeing little differently, and each eye is stimulated differently so that it can be improved. So this binocular vision stimulation is a new paradigm to treat amblyopia. And to speak more colloquially, we may say we have shifted from iPads to iPads, the technology. So how do we assess if a child is having amblyopia or poor vision due to any cause? You just examine the child. Now, for example, in the left-hand picture, you see a child having an esotropia, a convergent squint. The left eye is turning in. Now, if you cover his left eye, he doesn't mind because his main seeing eye is the right eye and he is not much affected. But the moment you cover his good eye, he is going to be very, very disturbed and he will revolt. He will not let you cover the good eye because his other eye is having lazy eye. So if this is the situation, it means there is poor vision in the other eye. If he was comfortably allowing you to cover any of the eyes, then it is equal vision in both the eyes, and that would not be indicating amblyopia. There are other tests. Now, this is what we call as the fixation preference test. Automatically, also some children may demonstrate sometimes seeing with the right eye, like in this child in the left-hand picture. You see he's turning his face to the right side and using the right inward deviated eye to fixate. On the other hand, he's switched his fixation to left eye fixation. Now, this situation also, if he's doing freely alternately, then it means equal vision in the two eyes. Then we look at his central steady or maintained fixation. That means the eye is maintaining good fixation centrally, steadily, and if it is maintained, it means it's a good vision. And if it is unsteady or unmaintained fixation, it indicates poor vision or amblyopia. So even if you have not been able to assess the vision in a child, you can clinically feel that there is some problem in the child. We need children to be shown toys or something which is more interesting to them. So rather than a torchlight, what we prefer is toys or some stickers which are put so that even for distance, he is able to fixate more with much more interest and use his accommodation. We can also use the ophthalmoscope at 1 meter distance and throw the light, and you see the red glow difference. Now, this is known as the Bruckner's fundus reflex. And if there is a much more brighter reflex in the deviated eye, you know that it is confirmed that it is a deviation and not just appearance of a squint, which is a pseudo squint. Special visual acuity tests are also there. Now, these are some photo screeners are also available, which are utilizing the principle of Bruckner's reflex, and it can automatically see if there is a change in the refractive error in the two eyes or if there is a squint in one of the eyes. There are methods of visual acuity which are primarily focused into three main heads: the detection acuity test like Catford drum, like candy beads or Steicar graded balls test, or the resolution acuity test based on the OKN drum, preferential looking PL test, and the pattern VEP, the visually evoked potentials. Or we have the recognition acuity. That means the child is able to identify a pattern which is different from the others. Now, these are more critical and they are the ones which are more important for using amblyopia detection. So we use picture identification tests. There are like Cardiff acuity cards or Oknovis, or the special pictures are shown. I'll show you the pictures, or direction identification of the letters. Now let's see, what do we do in small children? Birth to 6 months, you can use red reflex test or a corneal light reflex test. The red reflex test differentiates any corneal opacity, cataract or RD, as we had seen in the Bruckner's reflex. Or a corneal light reflex, you can see the different Hirschberg's reflex that will tell us about the strabismus. External examination like ptosis or anything which is obstructing the vision. So in the birth to 6 months, these are the simple things which a pediatrician can use or an ophthalmologist can use to know there is a problem. 7 to 12 months, you can use red reflex, corneal light reflex, of course, but then you can just do a fixation test for each eye, as the child has started fixating from the first month onwards, and even follow movements on the second month onwards, and you can then make your assessment. 1 to 5 years of age, you can also start doing the visual acuity tests. Initially the Teller acuity card, which are based on preferential looking. These are special cards which are having some lines which are going to be merged into oblivion on the other side. So if the child is looking at a pattern, he is able to distinguish it, and we see through a small hole in the center. And we can keep on changing from the grosser to the finer lines and know what is his threshold of visual acuity. So we had done a study and published, we had seen that around 1 year of age, the vision is around 6/24 in normal children. But if there is a refractive error, or if there is a strabismus or a media opacity, the vision drops from 6/72, 6/200, or even like 6/2000. The other set of cards, which are the vanishing optotype based principles, the Cardiff acuity cards. Now these are diagrams which will be becoming vanishing at a particular, beyond a particular distance. So these are also used for testing visual acuity in 2+ age children, or up to 3.5 years of age. And even older children, then we can use pictures or these Leah symbols, which are devised by Dr. Leah. And then we have these Sheridan-Gardner tests, some 5 or 6 letters which can be told to a child to differentiate or match, and then we can assess the vision at different ages. For older children, we have these logMAR, logarithm of minimum angle of resolution, the ETDRS charts, also the short form of early treatment diabetic retinal study. So that are also being used. The near vision charts are also used for even adults to know if he or she has a presbyopia. So these also can be used for children. So this is a small set of summary you can remember. Age appropriate vision tests that we would like to see. 3 to 18 months, the preference looking test, the Teller and Keeler. Vanishing optotypes 12 to 30 months. Picture matching 2 to 4 years. The single letters 3 to 5 years. And the other older children, we can do the linear Snellens or logMAR visual acuity charts. For binocular assessment, we can use the Bagolini filters, which are basically striated glasses, and a light source of light is seen as lines, and the child will tell you whether he's seeing a single line or a cross if he's seeing both the eyes equally. Or we can use red and green glasses, and the Worth 4-dot test can be done. A simple test like a Lang's 2-pencil test tells us that he or she has or not stereopsis. Now, you are holding a pen in your hand, and the child is asked to touch the tip of the pencil in your hand with the tip in his or her hand. And if the child can do it, it's only possible if both the eyes are having good vision and in alignment. And if you cover one eye, you'll see immediately he will falter. So any problem in one of the eyes will be picked up if it is gross, that there is abnormal Lang's 2-pencil test. We can also assess the stereopsis of the child by using specialized tests like the Rendot with Polaroid glasses, or the TNO, which is using red and green anaglyph filter glasses. There are specialized tests for distance like the Frisbee-Davis distance test, FD2 test, which are real dimension tests in which we are moving one of the optotypes forwards or backwards and asking the child which is appearing to be displaced. The distance Rendot is again based on the Polaroid test. Another function which we need to assess is the contrast sensitivity of the two eyes, of each eye. And we know that in amblyopia, the contrast sensitivity also gets affected. When we are dealing with squint, we will be now looking after certain other things like the squints or deviation in different gazes. In primary position, as you can see, this individual has an outward deviation, exodeviation. In looking down, infraversion or up supraversion, the deviation is changing. It's less in the down and more in the up gaze. It is also changing on the sideways. You can see there is a vertical deviation of the inward turning eye. So these all can pick up different deviations by your good observation. So what you need to do is a good observation which is there. So taming the terrible is possible if you are having this simple approach, what I generally call as my recipe in strabismus, the OCIPE. Observe, confirm, infer, plan, and execute. Because a child is not going to give you much more time, you have to be very observant. Then you can do simple tests like cover test to know if he or she has a real squint or a pseudo squint. Then of course you can infer, plan, and execute your thing. Now this picture shows you that in the upper one, you appear to have a child having a squint inward deviation, but this is not true squint because you'll see that both the eyes are symmetrical. And if you do a simple cover test, you'll find that the eye is not moving. So it is not a true squint, but a pseudo inward squint or a pseudo esotropia. Now many children who are having a telecanthus or epicanthic folds, what we call as having Japanese eyes, they will appear to have the pseudo esostrabismus. Or they may have a large palpebral aperture, as sometimes they say Mrignaini, that large palpebral apertures, they may appear to have a ESO deviation like the middle picture. And sometimes we can have pseudo-exotropia, the appearance of having the eyes into outward deviation, which may be giving rise to this situation. How do you know? A cover test. So look at this, what I'm doing, a simple thumb. So just covering one of the eyes, and you can see that the eye is not moved if there is no true squint. And if there is a true squint, you'll see that the eye has moved. Now the left eye, which was appearing inwards, has moved. If you see this video now here, now this eye, left eye appears to be squinting. You cover the right eye and the left eye is moved out. It's a very clear test that this is a true ESO or a convergent squint. Now here the eyes are both straight. So what is the problem here? If you cover the eye, and now look what is happening. The eye is moved out under cover, but then they came back. So this is an intermittent divergent squint, and the amount of time it takes to recover tells us how good or bad the recovery is. So this is an intermittent divergent squint. Okay. And then once we have a squint, we'll measure it using prism bars, a prism cover. These are basically prisms stacked in a one prism bar, and you can easily do the cover uncover test for the thing that how much is the deviation. Very small children who do not allow like less than 6 months, you may use the Hirschberg's reflex, but for older children, we should always go by the prism bars. And we can do a simultaneous prism or an alternate prism cover test. Now here what we are showing is a simultaneous prism cover test. See here that same child having an ESO deviation, and now we are going to neutralize the deviation, and we keep on increasing the measure of the prism till we get a neutralizing point that there is no cover and cover movement. Okay, so we know that okay, this is 30 prisms of esotropia. We should not stack prisms one over the other on the same eye, because then the measures will be wrong, because 2 plus 2 is not 4. When you stack them, it becomes 5, as we can see here. So never stack them one over the other. You need to use the same over the two eyes. You split them between the two eyes. Even a child having a high aphakic correction will have an induced prismatic effect. So be aware of this. And high myope or high plus correction, you need to make corrections done if you have measured it. Then error becomes very significant for more than 20 prism diopter deviations, and especially for more than plus or minus 5 diopter powers. So these are the tables which are there for you to understand that what is the correct deviations. When you look into the fundus, you will see that in this upper picture you have an extorsion. The fovea is much more displaced. It should have been between the two horizontal lines like in the bottom picture. So what is there is a extorsion because of an inferior oblique overaction. And after the surgery, in this case, the lower picture is showing you that the eyes have become normal and the extorsion has been corrected. So this is if you take a fundus picture, you can see the same and measure it on indirect ophthalmoscopy or fundus photography. And even a blind spot charting can tell you this. So we can measure the torsion by different tests like diplopia charting, the Lancaster red-green, the double Maddox rod, Bagolini loose glasses, synoptophore with after image slides, or a Polaroid stereo projector. But the simplest one is the double Maddox rod as shown on the side picture here. And we see these two double Maddox rods, and the person will see the two horizontal lines, which is one of them will be tilted, and you can tilt the rod, the Maddox rod, to and find out how much is the torsion which is correcting it to horizontal parallel lines. So accommodative squints, we have to be now careful. Now these children, if you have a squint, always do a full cycloplegic refractive error correction. That means under 5 years, use atropine for cycloplegia in Indian eyes particularly. And older children, we may use home atropine to get full cycloplegia and then give full correction. And as you can see, the esotropia just can be corrected by using the proper glasses. No squint surgery is required for these corrections. Then you have to use properly accommodative targets. Otherwise, the child may not accommodate and you may miss the accommodative esotropia. Now here the child was having straight eyes for distance, but the moment I brought the object of interest close, the eye turned in. Now such a child requires near extra correction or bifocals. And these bifocals have to be proper fitting, the executive type or the high D, so that the correction is all the time for distance as well as for near. Now this child is having a partially accommodative. Even with the glasses you find for distance, there is a inward deviation in the left eye. Now this child will require either prism correction in addition to the glasses, or if the deviation is more than 20 prisms, usually we'll have to do a surgery to correct the deviation. And these are for more theoretical thing. We can measure the AC by A, accommodation convergence divided by accommodation ratio, by either the heterophoria method or the gradient method, and to measure how much is the AC by A ratio. For more detailed times, we can discuss this in some other avenue. But the children who are having different deviations for distance as well as for near, like this exotropia is having a exotropia much more for distance 6-meter fixation than 33 centimeters. Now this child will have a divergence excess exo. Now these have to be treated differently. Similarly, this individual has more exo for near. So we need to see them for different distances also, what is the deviation. So just to put it in short, differences between distance and near fixation helps us to determine an esotropia, whether it is a basic type, that means both distance and near measurements are the same, a convergence axis, more ESO for near, or a divergence insufficiency, more ESO for distance. And the exotropias, basic means the same deviation both for distance and near fixation. More exo for near is convergence insufficiency type exotropia, and more exo for distance is divergence excess exotropia. The measurements in different gazes will tell us if there is any incompetence like a paralytic strabismus or a restrictive strabismus. Up and down measurement, as we had seen, will tell us if there is an A and V pattern. Deviations in different eyes will tell us if there is a primary versus secondary deviation like in a paralytic squint. And if we find that the subjective versus objective method is different, it will tell us whether it is a normal retinal correspondence or an anomalous retinal correspondence. Deviations after prolonged cover can differentiate a true divergence excess from a simulated divergence excess, as well as a partially compensated exotropia. And deviations with and without glasses tells us between the accommodative squints. The up and down measurements like this picture shows you a V pattern and an A pattern, more exo in the down gazes, and which also we can measure. Like in this person, we see the exo is much more in up gaze, and also find that the inferior obliques are overacting. Now these children will require specific surgery to correct the inferior oblique in addition of the lateral rectus surgery. Here the exotropia is without inferior oblique overaction, but the V pattern needs to be corrected. So this will be done by another mechanism, not by inferior obliques, but by shifting the horizontal recti. Similarly, the superior obliques can cause an A pattern exotropia, and without superior oblique overaction, we may have an A squint, which also needs to be corrected. They may be again asymmetric between the two eyes. So your observation has to be for each eye and then take an account of it, and then we can plan the surgery. Like this individual or child has straight eyes in the primary position, but looking up there is a more exo and ESO in the down gaze. So these are V patterns. And now after surgery, they are corrected. So DVDs are dissociated vertical deviations that behind a partially occlusion, you might see an eye moving up. So this also we can observe and treat it and use a Spielman occluder to detect it in addition. So paralytic strabismus, we do special diplopia charting. That means red and green glasses are tested, and the person is tested for distance, that how much separation is there between the red and the green images. And this will tell us like a horizontal separation here in this picture. There are special tests like least charting or Hess chart, which can also be used to document the paralytic strabismus. And then we document them in these charts. So PGs may be more familiar with these things shown for exam in the examination, and they are supposed to tell us whether it is a third nerve palsy or a fourth nerve palsy or a sixth nerve palsy, like in this, or both up and down measurements being limited, like in a blowout fracture of the right eye. Then we have the binocular fields of fixation. That means diplopia-free gaze, which is there. Normal diplopia-free gaze is shown on the upper hand corner. And in this case, there is a limitation of in the down gazes causing a diplopia in the down and little left gaze. How do we manage them? We can give glasses. We can correct amblyopia, as I told you earlier. And so small deviations, we may give prisms or correct them with exercises. But larger ones, we may use the surgery. And torsion also, I told you how we can correct it by surgery. These are examples of Fresnel prism. These are membrane prisms which can be stuck on the back of the glasses to correct the deviation. And we can improve fusional convergence by exercises as shown here. There are over minus lenses. That means we can correct some exotropias by giving them over -2 diopter if they have a high AC by A ratio. So this is for limited use that we can make. But coming back to our primary thing is strabismus surgery, which we may do a recession. That means shifting the insertion of the lateral rectus or a medial rectus towards the origin. So this is a recession. And these may be done by a conventional approach or maybe by a hang-back approach, which can also be used as an adjustable surgery. We may also do a marginal myotomy in some limited cases. Strengthening we do by resection, that means removing the tendinous part and tightening the muscle. The simple rule is that if you make the muscle recessed, you make it lax. Like a lax student is weak. Similarly, a taut student, a tightened muscle or a taut muscle becomes strong. So like a taut student is strong and a lax student is weak. So remember the simple analogy that recession is a weakening procedure and a resection or a plication is a strengthening procedure. In 1 or 2 minutes, we'll just see what is the surgery done. Like nowadays, we do a fornix incision approach. We make a small cut in the conjunctiva, go into the subtenon space, hook the muscle with the special hook, the Jamieson hook, and here the lateral rectus is hooked. And then we are going to remove the conjunctiva in front and get the muscle in our exposure. This is the muscle out in the field of thing, and both the sides, the intermuscular septum is separated so that we are having the full muscle in our width. This should be ensured, otherwise you'll have bleeding. If you do properly, you'll find muscle, though a vascular structure, will not bleed. And then once we have done dissection on either side and removed the check ligaments here, right here, we'll pass sutures, the 6-0 vicryl sutures, which are absorbable. The 6-0 vicryl sutures are used here. These are pass one central bite and then interlocking bites at the two ends, and then you can disinsert it. Now after this you can reposition it and then it will cause a recession. As I said earlier, a muscle coming close to the origin will make it lax, so there will be a recession. So here when we are passing the sutures in the sclera, we have to be ensured that we do not perforate the sclera. So it's a partial thickness bites and the measurements are properly taken, and then we pass it in the sclera, partial thickness as you see here, and then you can tighten this suture. I think because of limited time, we'll skip the more details. But remember, when is the timing? The early alignment is what we recommend. And here the two words are important, early and alignment. So there is no point of doing a partial surgery in a child. You have not gained anything. You have to do a full alignment, but early enough. Now this case history is of a child who was born, newborn with straight eyes, but he started turning eyes in at around 3 months of age, which is the usual story of an infantile esotropia. And here this father is Dr. Kenneth Wright. So he's the child of Kenneth Wright. He saw that the child is turning in. He gave him glasses. In spite of glasses, there is an esosquint on the Bruckner's reflex. So he was operated at 6 months of age. Having full alignment early enough, he has normally developed stereopsis. So this is what we are now looking forward to giving in each and every child. And fortunately, many of the people who are now following the technique that we are describing, we are able to get these children to get back their normal stereopsis. And that is what I say, the pursuit of stereopsis. So when do we target? Congenital cataracts, as you all may come to know, it's 4 to 6 weeks. Infantile esotropia pick up by 4 to 6 months. And in other squints, we'll do by 4 to 6 years. All corrections should be made by 6 years of age. So just like in cricket, we have the importance of 4s and 6s, we have to remember these two catchwords. In exotropias, see if there are intermittent, we can wait and watch till the time the stereopsis is maintained. But then if they are manifest squint, we will have to correct them in order to restore the stereopsis and don't want to lose their binocular vision advantage. So this child who is having a constant squint even in early childhood, we have corrected it and restored his eyes in alignment and got him back to stereopsis. So we have to be squintellectuals, not just intellectuals. We have to be squintellectuals so that we can correct the squints in all the gazes and restore the alignment and the binocular vision to each and every child of our country as well as the globe. And this is the message that I would like to give, the pursuit of stereopsis. The goal post is not having just good vision in each eye, but to restore binocular vision, good stereopsis with good fusion. And we are not just treating strabismus, we are restoring binocular vision and stereopsis. So our mission is spreading sight and happiness for kids the world across, maintaining the stereopsis and restoring the loss. So for more detail, you can always come back to me on the email or the other doctors in your area and learn more, but keep yourself enlightened so that you can help the children of our country as well as elsewhere. Thank you so much for your patient listening. And for any questions, I would be very helpful to answer. Thank you.
Thank you very much, sir. This was really wonderful presentation. And I would say, sir, the way you taught all of us using the example of Mary's, then using the examples of like different kind of personality kids, and then the way of examining a child's sight, that was really very innovative ways were included, sir.
Thank
And
you, Jaswant. Thank you. It's a pleasure. Thank
sir,
you.
and for the treatment also, like using surgery videos, and it was so easy to understand. Well, it's so easy, like being psychiatrist and being away from the ophthalmology for around 15 years. Like I was learning a lot. So thank you, sir.
Thank you, Jaswant. It's a pleasure. And that is the purpose, that we want each and every person to be interested. Even if he's not doing ophthalmology, he would be picking up the cases of squints or the poor vision and then get him corrected.
Sir. Thank you, sir. So I request the participants, if they want to ask. Well, what I think that the lecture itself was so explanatory and so easy that there is a very low possibility of any doubt. But still, if anyone has any
Sure.
doubt, any query, any kind of questions, so please feel free to ask. And even if you raise your hand, we can unmute you, and then you can ask the questions.
I think there's some hand.
Yes, Dr. Raja Rajan, please unmute him.
Yeah, unmute him. I think he's still muted.
Rajarajan sir, you are on two devices, so please unmute one of the device. Raviji, can you please unmute Dr. Rajarajan?
Yes, I'm asked you.
Ji, please.
Raja Ravi, and yourself.
सर राजाराजन सर, आप अनम्यूट कर लीजिए, आप हम सुन नहीं पा रहे हैं आपको. Sir.
I think he's not getting the message. Yeah. So if there is any message on the chat, we can take up. If they are not able to unmute, you have. There are other people on the chat. You can just click the chat. That's just check. Yeah.
No, there is no question.
Monitor read here. Yeah.
Are you able to hear?
Yes, sir.
Yes,
now
yes,
we are
yes.
able to hear you.
Yeah.
Yes.
Sir, it's an extraordinary lecture. I salute you for an exemplary, only from an exemplary medical teacher, this kind of talk could happen. And it is exhaustive, lucid, vivid, and it is apt with apt patient pictures, step by step, crystal clear. And I have to convey you that it is a very useful talk to our Tamil Nadu PG medical students as well as the young faculty members. Really, I thank you very much on behalf of the Tamil Nadu NAMS chapter.
Thank you, sir. Thank you. Vanakkam. Vanakkam. I think Jaswant, now you are muted.
Sorry, Dr. Prashant raised his hand. So, Dr. Prashant, you can unmute yourself and you can ask question. Yeah, please.
Good afternoon, sir. Thank you very much for this informative session, sir. Sir, my question was that what are the long-term consequences of untreated strabismus in children, and if timely intervention is given, so how can it impact their quality of life?
So wonderful, Prashant. I think what I was mentioning earlier also, that if you can correct the squint in early childhood, then we can restore the binocular vision. So if they are not corrected in childhood, you may only correct them cosmetically. So many a time the olden ages we may have had this concept that the squint is to be corrected just before marriage, and they used to wait till about, and many doctors used to just send them off that come just before marriage. That's a wrong concept. We are not having the two eyes just for cosmesis, but for actually having them to be used together for binocular vision. So if we can treat them in early childhood, we can not only make them straight, we can also make them functional and have normal stereopsis. Now, what is stereopsis? 3D vision is so much important for so many jobs. We don't actually estimate the advantage of that as long as we have it. Just like when we have the electricity, we don't find the fun of it. But when we lose it, we'll see that a child who's having 6/6 vision but not having stereopsis will not be able to qualify even for driving that way, because that also requires good stereopsis. Flying, of course, is totally out of question. And many other jobs like doing a precision surgery again requires good stereopsis. So if you can really pick up these children early enough, and if they require, we need to see that they are corrected. It's not only squint, it's also like refractive error. So nowadays we have become more and more aware of this fact, and we are getting children early that we are putting up glasses. And we have to teach them that there is no stigma of glasses. The stigma is have poor vision. If a child has poor vision, that is a stigmatic thing. But if you have glasses and you have good vision, it is actually a hallmark of early detection, I would say. And I generally tell children that it only indicates that you are educated, that you have come to know that you have glasses. An unpad will not, or an uneducated person will never realize the importance of glasses. So that's another thing which we need to correct. So any eye problem, we need to correct. Yes, there is some other hand which has been raised. Thank you, Prashant. We can move to Dr. Ishita.
Ishita, yeah, please unmute yourself. Yeah, you can ask.
Good evening, sir.
Yes, good evening, Ishita.
Thank you for such a wonderful lecture. I just wanted to ask, how would we prescribe patching for a child if he comes with the strabismus? Like in our case, I found a child, 11-year-old girl. She came with left eye exotropia, and she was having hypermetropic refractive error, sir.
Okay, good. So Ishita, you have raised a very good question. For the clarification, I'll just say that actually the exotropia itself is not necessarily the cause of amblyopia in this case. The problem is with the anisometropia, which has caused amblyopia. And what we'll need to do at the 11 years of age, the option is, because she is going into school, she may not be very amenable to a full-time occlusion, although the older times we were used to give full-time occlusion, and that would have been 6 days a week, good eye being patched, and one eye, the amblyopic eye was be unpatched on that day. But nowadays what we follow is a part-time occlusion. That means 6 hours every day, the good eye that will be patched. So the eye which is having the better vision is patched for 6 hours daily, and the glasses are given full time, so that the person will be using the vision with glasses. And here in addition, we should also encourage them to use some active vision exercises, like maybe threading a needle, reading books, or maybe just coloring the books, or dot and painting or whatever, so that the amblyopic eye is more and more used. We can also encourage them to use the video games for maybe half an hour, 1 hour, if they have patched for 5 to 6 hours. So as an incentive or reward, we can give them this further thing advantage, that they can use a video or even virtual reality games. We can make them play with both the eyes nowadays.
Thank you, sir. So, as we say, the plasticity age is up to 8 years. So, till how many years we can prescribe patching to a child in this?
Again, I think it's a very good question for the purpose of everybody's knowledge. The concept of this plasticity age is now, obsolete. What we say is, and that is true, just like as I said, vision is a language. Just like any language, you can learn at any age. If you were in China, you would have learned Chinese easily. But if you are posted in China for long at the age of 40, will you not be able to learn Chinese? You can, but it will be very difficult. The same, if you want to treat amblyopia, even at 11 years of age, you can start treating him, provided one, that the starting vision is at least 6/60 or better. So that means you patch the good eye and he's able to be using it workably or usefully. If the vision is very poor, less than counting finger 1 meter, obviously this is not going to work. Unless we can bring the amblyopic eye vision to 6/60, patching for long hours is going to be more like a punitive action or a penalizing the person. So if the vision is not that bad, you can patch at any age, even if it is 11 years, provided the person is motivated. And we have seen even people at 20, 21 years of age, because they came to know only at that time, the vision was, let's say, 6/24 in the amblyopic eye, and it was anisometric amblyopia. And we have got wonderful results by patching even at 21 years of age. So age is no bar.
Thank you, sir.
Thank you, Ishita. Any other question? If anyone wants to ask or wants to clear their doubts, they can ask. Okay. Just for the participants, Sir has a very active YouTube channel with the name of Dr. Pradeep Sharma Eye Surgeon. And
Yeah.
I just saw that, sir, you have around 1,000 and I think 32,
Yeah.
1,320 subscribers. So they are exponentially increasing. And I saw that sir is singer, no doubt. Music is there, which is hobby. But
Yeah, that's
apart from
Travis music.
yes, sir. But apart from music, sir's mono acting on Gandhiji and Gandhi Jayanti and other talents are also visible on the
Okay.
YouTube channel. So
Yeah.
that's what.
Yeah, the videos are there. Many of the people who are using that, the videos, I think I'm very happy. And that is the purpose. And if you want more and more videos, we can upload more. And they are very much in use all over the world. Many people are using those videos for surgery. I feel very happy.
Sir, please keep uploading and we will keep on visiting your channel. So
Thank
that's
you,
very
Jaswant.
informative, sir. Thank you, sir. So I think now it's turn to.
Sir, your comments on medical illnesses and strabismus.
Yeah, Sangram, sir, please.
Medical illnesses and the strabismus.
Yes. Is that a question? Yeah.
Yes. Sir, regarding the...
Sir, Dr. Sangram wants your comment on medical illnesses and strabismus, the relation or maybe the link.
Yeah. So eyes, as we know, are part of the body. So there are many things which are going to be having that. For example, you have particularly in the neuro-ophthalmology, we have much more links because eye is much more closely related to the brain. So the cranial nerves, as we know, they are like the third, fourth, and sixth nerves. So if there is any head injury, any problem with the brain, sometimes any of these nerves are affected, you have a paralytic strabismus. In addition, there can be tumors like thyroid eye disease also in addition. So they are also cause some strabismus. So many situations in the systemic disease will also create problems. Diabetes, for example, uncorrected diabetes or hypertension can give rise to an ischemic neuropathy, which will give rise to a sixth nerve or third nerve palsy, which can be presenting. So we need to see into that. Whenever we see a person having a strabismus, we need to focus into this. Sometimes a papilledema or a raised intracranial hypertension, which will be silently, the vision will be okay in these children for quite some time, but they will just present with an esotropia, we say as a non-localizing sign of an raised intracranial pressure, the idiopathic intracranial hypertension. So these are again telltale things that we have to investigate. So whenever you have a person having a esotropia, paralytic squint, always look for the causes that may be there, like a blood sugar, blood pressure, or look into the fundus, that if there is a papilledema, we need to order an imaging thing. It may be a tumor which may be causing any of these third, fourth, or sixth nerve involvement. So there are many other systemic conditions. Thyroid eye disease can be affecting it. So we need to be aware of this. Thank you, Dr. Sangram, for asking that question.
Thank you, sir. Thank you.
Thank you, sir. Was a wonderful presentation and interesting discussion. So Now I think I would like to invite Professor Ajay Kumar Sood, sir, for the word of thanks. Sir is Deputy Secretary at National Academy of Medical Sciences. Over to you, sir.
Thank you, Dr. Jaswant. Indeed, on behalf of the National Academy of Medical Sciences, it is my great privilege and pleasure to thank the distinguished speaker for this afternoon, Dr. Pradeep Sharma, sir. Thank you, sir, for your very important topic, which you have made it so easy and understandable to all of us, including the postgraduate student, by including video clippings. And as Jaswant also mentioned, the presentation itself was very, very informative for all of us. Thank you, sir, for your valuable time, and we look forward for your support in future also. I will also like to thank the chief coordinator for this series on ophthalmology, Major General J.K.S. Parihar, sir, who has selected the best topic and the best speaker, as you have seen today. So please do join us for the rest of the series. The next session is due on 4th of July. And there again, we have a very important topic of diabetic retinopathy, which is being covered by the professor of ophthalmology from AFMC Pune, Colonel Vikas, sir. So please do join. And if you have any question related to this, please write to us. We'll try to communicate these to the speaker. And also, I would like to thank all the participants and especially the dean directors and senior faculty members from AIIMS and other institutions who have made this program successful. And we seek your cooperation and support. Please give us your suggestion and also come forward to take topics of your interest. We'll be happy to share this details with the students, and you please come forward. For the student information, this series on ophthalmology is going to cover, as Major General Parihar also mentioned, other topics are like on glaucoma, surgical management of glaucoma, management of trauma in injuries of ophthalmic injuries in pediatrics, and also a very important topic of eye donation and that. So please be with us, and we have circulated the detail of this brochure on the chat box, so you can have the link as well as you can inform other colleagues. So for the information, we have another interesting online program information on with collaboration with IIIT Hyderabad, that is on artificial intelligence in healthcare. So please, the brochure is already in the chat box. So if you're interested, you can apply. The next session is going to start in the next week, perhaps in the June. Another information is for senior faculty members. National Academy of Medical Sciences has started recognition of academic excellence, and we have circulated letters. And again, the chat box, we have the detail. The online applications are invited. We have 24 themes, and 2 or 3 themes are on ophthalmology as well. So senior faculty members can always apply for that. Last date is 30th of July. And in addition, I would like to thank Dr. Jaswant, who has been associated with us for a very long time, right from the very beginning, helping us in moderating this session. Despite being busy today in a meeting, he was able to find time. Thank you so much, Dr. Jaswant, for your support to the National Academy. I would like to thank our team here under the leadership of our secretary, Professor Umesh Kapil. They have been working. Mr. Ravi, who is our IT officer. He is organizing all these sessions on YouTube as well as sending you letter. Mr. Shivam, who is helping us. So once again, thank you all for being with us. And once again, thanks to the distinguished eminent speaker for being with us. Over to you, Dr. Jaswant.
Thank you very much, sir. So I think now we can call the closure of the session. So thank you, everyone. Thank you, sir.